Good afternoon. Welcome to Pulmonary Grand Rounds. It's my pleasure to introduce Dr. Elizabeth Klings as our speaker today.
Are you using this thing?
I don't know. Do I need to use this?
No, you don't.
Okay, I think it's just this.
Got
Dr. Klings comes to us from Boston University School of Medicine, where she is a professor of medicine, director of pulmonary hypertension, and the director of clinical research at the Center of Excellence in Sickle Cell Disease. She's an accomplished investigator in the field of sickle cell disease and its pulmonary complications. Her research has led to the development of clinical guidelines for the ATS on the diagnosis and treatment of PH in sickle cell disease. So please join me in welcoming Dr. Klings to Grand Rounds today. And I look forward to her talk about sickle cell disease and its pulmonary complications.
Yeah. Thanks. Thank you so much for having me. I'm Liz Klings. I have had a very interesting career path, but I've also had a very interesting day here at Yale, and I've really enjoyed meeting everybody. I hope you weren't coming to hear purely a pulmonary hypertension talk, because this is really much more of a talk for me as a hematopulmonologist, working as a pulmonologist working in the sickle cell disease space. But hold on a second. How do I get to this? My disclosures: I do a lot of clinical trials work, predominantly in sickle cell disease, occasionally in pulmonary hypertension. And so why are we thinking about sickle cell disease as pulmonologists? Well, a little bit about this disease. This is an international disease with 250 to 300,000 births occurring each year worldwide, predominantly in sub-Saharan Africa and India. However, here in the United States, we have approximately 100,000 people living with sickle cell disease. And this is a disease of accelerated mortality. And this is a disease where the cardiopulmonary complications account for at least 20 to 30% of deaths. And so, I know my audience, and I am a full-fledged pulmonary and critical care physician. And when I give this talk to our fellows over at Boston University, none of them have any idea about sickle cell disease. So we're going to start at the very beginning. Not that I'm assuming that that's where you're starting, but this is a genetic hemoglobinopathy. And so the genetic disease is inherited in an autosomal recessive pattern, and hemoglobin S is the gene of interest. And this is formed by a glutamic acid to valine switch at the 7th codon of the beta globin chain. And so sickle cell anemia is a little bit of an outdated term, but it refers to people who are homozygous for that hemoglobin S mutation. They have hemoglobin SS disease, and it's the most severe disease. And in the United States, we're looking at a median survival into the 50s. Hemoglobin SC disease is a compound heterozygote of hemoglobin S and hemoglobin C, which is a glutamic acid to lysine switch in the same codon of the beta globin chain. And so this was used to be thought of as a milder form of sickle cell disease. You'll see from my second case, not so mild, but these patients do have a lower rate of complications and a longer survival, except for retinopathy, which is, for whatever reason, more common in patients with hemoglobin SC disease. Hemoglobin S, beta thalassemia. Thalassemia is an absence of a beta globin chain. And so you can either be beta 0, meaning no beta globin present, or be beta plus. And so beta 0 patients are more similar to hemoglobin SS. Beta plus, more similar to hemoglobin SC. Sickle cell trait, another poorly understood condition, used to be thought of as totally normal, and it may be for many people totally normal. It's the presence of one hemoglobin S gene, and hemoglobin A is the normal hemoglobin gene. But we're now starting to understand that there may be an increased risk of renal disease, thromboembolic disease, and possibly exercise-induced cardiac arrests in these patients. So why do people with sickle cell disease get sick and die early? One of the misnomers about this disease is that it's not just an anemia. This is a diffuse systemic vasculopathy that affects almost every vascular bed in the body. But the interesting part of this disease is that everybody shares the same hemoglobin mutation, but not everybody has the same amount of complications or disease severity. But chronic organ damage, and the organs I'm talking about are the lungs, the heart, and then those other two things, the brain and the kidneys, that really is the reason our patients are dying. And we don't have any effective specific treatments for this. But most people who know something about sickle cell disease know that chronic pain, both and acute pain and acute vaso-occlusive crises, is the primary reason that our patients are getting hospitalized. So we are pulmonologists. And so for a pulmonologist like me, this is a disease that affects almost every cell type and structure within the heart and lungs. And it ranges from acute complications, including the acute chest syndrome, but also pulmonary thromboses and pulmonary emboli, to more chronic conditions. And we're going to touch upon pulmonary hypertension, congestive heart failure, particularly in this talk, but also touch on a couple of other things related to the other diseases listed here. So I'm framing this talk around two patients. And if I can get the slides to advance. My first case. So this is a 22-year-old female who has hemoglobin S, beta thal plus, and asthma. She's on PRN albuterol, who comes in with increased pain in her legs and her arms for about 2 to 3 days. This is worse than her typical vaso-occlusive crises. She has some right-sided chest pain. She's followed intermittently at Boston Medical Center. That's our primary teaching institution. And she's actually followed by our pediatric program because we transitioned late at age 23. Due to the frequency of her vaso-occlusive crises, she was started, even though she has one of the milder genotypes, on hydroxyurea in the past year. On her presentation, she's not febrile, but she is tachycardic. She's satting 96% on Humira. Her blood pressure's fine. Her exam's unremarkable. In her white count, she has leukocytosis, and her hemoglobin's at a baseline of 11.6 grams per deciliter. But interestingly, her platelet count is 140,000. And this was a tip-off that things were going to go bad. Because typically our patients with sickle cell disease, particularly when they present with vaso-occlusive crises, will have a reactive thrombocytosis. And so when you see the platelets go down, it's a sign of things to come. She has some hemolysis going on with an elevated bilirubin and AST, normal renal function. She's given IV opioids, started on a morphine PCA, and placed on intravenous lactated ringers at 100 an hour. The plan was to admit her to the floor, but there were no beds. And so in the ED, she remains. 3 to 4 hours later, her mental status is off the wall. She's awake, she's thrashing. This is a 22-year-old woman. She's unable to assess her motor strength. She's alert and oriented times 0 to 1. She's somnolent sometimes, then she's agitated. She's also hypoxic. She's satting 84% on Humira. They put her on 4 liters, and she's now up to 91%. And she has crackles through both lung fields, and she's still tachycardic. And so they get an X-ray. And this X-ray is a little bit out of order. I left the X-ray out of this talk. So the X-ray shows it's a portable film, not a great quality. There's a lot of soft tissue. She's obese. But there is suggestion of there being bilateral infiltrates, but involving probably both lower lobes, here, and then probably posterior there in the superior segment. And this is acute chest syndrome. And so acute chest syndrome is defined as an infiltrate that involves at least one segment of a lobe in addition to symptoms. And these symptoms range from fever to hypoxia, shortness of breath with associated hypoxia, chest pain, wheezing, chest retractions in kids. Acute chest syndrome is, in my opinion, the worst diagnosis in internal medicine because it's an umbrella term and encompasses numerous other diagnoses. But what do we do for these patients? We like to transfer them to a higher level of care, typically the intensive care unit or the step-down unit, although some patients may be able to be managed on the floor. But we also do a lot of things that are really just supportive care. And we use incentive spirometry, and we use this both for prevention of acute chest syndrome, and there's some literature to back that up, but also for treatment and prevention of progression, because atelectasis is one of the triggers for this condition. We know that in some patients, there is an infection that is the trigger. And so we know that the atypical organisms, particularly chlamydia, Legionella, but also some of the viruses, are the most common organisms isolated. So we often will use antibiotics, but we also think about transfusion, and we think about it to reduce the hemoglobin S fraction. And the reason, and so this can either be by just giving people blood, and that's what a simple transfusion is, or doing an exchange transfusion. Because, and the way the exchange transfusion works is to reduce the viscosity of the blood. And so we know that when people have with sickle cell disease have a hemoglobin of greater than 10, there's increased viscosity, and that promotes erythrocyte sickling. And that actually will worsen this process. The process of exchange transfusion involves removal of blood and exchanging it for hemoglobin AA blood and reducing the risk of that. And we use a lot of bronchodilators, particularly albuterol in this setting, because if you do spirometry of patients in the ICU, we do, what's it called? It is often an obstructive pattern that's seen, even in adults. And so we've been doing some work at Boston Medical Center in how do we prevent severe ACS. And one of the problems of acute chest syndrome as a diagnosis, it actually encompasses numerous diagnoses, ranging from pneumonia to things as complicated as fat emboli syndrome. But it also includes things like congestive heart failure and atelectasis. And so there's different diseases that are at the etiology of this. One of the things that may precipitate it is atelectasis. And so we know that at night, our patients are not able to take deep respirations, particularly if they're on parenteral opioids. And one of our pediatric pulmonologists, Robin Cohen, developed a protocol to use non-invasive ventilation on the floor in patients who are high risk for acute chest syndrome as a way of preventing this. And she rolled this out as a clinical quality improvement project on our pediatric unit between February 2017 and February 2020, covering about 53 hospitalizations of 23 patients. And these patients could have had mild to moderate acute chest syndrome to start with, but they were really people who had sort of were at risk for higher severity acute chest syndrome. And so these were people that either had prior episodes of acute chest, had chest pain or back pain, or were hypoxic. And this was really a feasibility study, and she was able to use non-invasive ventilation or have successful use in about 75% of patients for 2 nights or more. And 88% of the patients who received the nocturnal BiPAP, and this is really a way of using incentive spirometry when you sleep to prevent atelectasis, did not develop this. And so we launched a similar adult protocol in January of 2023 and really focused on the patients on the adult side who were going to become hypoxic at night. So they either had known sleep disordered breathing, particularly obstructive sleep apnea, they weren't on PAP, at home. They were hypoxemic at baseline. They had underlying pulmonary hypertension or underlying prior severe acute chest syndrome. And we're starting to see a possible reduction in the need for the ICU and also a need for the use of transfusions. And that's data we presented at ATS last year. What do we know about non-invasive ventilation for treating acute chest syndrome? Well, what we know is that what's been published in the literature is a prospective single-center study of 71 patients, and they were randomized to either oxygen or an intermittent non-invasive ventilation for treatment. And these using settings of 12/5 and with a goal tidal volume of around 7 milliliters per kilogram. And it was basically done every hour and 1 hour out of every 4 for about 3 days. And so what they found was that they improved oxygenation more rapidly, immediately, but by day 3, the difference was not really appreciated. So we use BiPAP like we do for many other conditions in the ICU to try to help with oxygenation and potentially ventilation in these patients, but it's not clearly been shown to be beneficial in acute treatment of ACS. So let's get back to our patient. This is going to be a little bit more than just bread and butter acute chest syndrome. So she's now in the ED, thrashing, completely out of it at times. And she has a respiratory viral panel that's negative, including both for COVID and influenza. Her white count is now worsening. It's 23.4. Her hemoglobin is dropping. Remember, it was in the 11s to begin with. Now she's at 7.8, and her platelets are dropping. She now has an AKI with a creatinine of 1.2, and her LDH is very high, 2374. And an LDH in sickle cell disease is almost entirely from the erythrocyte. And so this is suggesting that she's really hemolyzing, and that's why her bilirubin's up to 6.2. She gets hematology is now involved. She is being transfused. They want to recommend transfusion and starting her on ceftriaxone and azithromycin. Ceftriaxone to cover pneumococcus, H. flu, the encapsulated its organisms. Our sickle cell patients are asplenic or functionally asplenic or surgically asplenic. And so this really gets back to, well, what's going on physiologically within the vasculature of our patients with sickle cell disease. So everybody I told you has the same hemoglobin S mutation. But if you look at the blood vessel, and this is a figure from that was created by my mentor Marty Steinberg many years ago and published around in 2000s, what is happening is actually a dynamic process within the vessels. And this is the vessels throughout the body. This is sort of indicating sort of a more peripheral vessel with a branch point here. And so what you are seeing in vaso-occlusion is abnormal adherence of circulating red blood cells, white blood cells, and platelets with the vascular endothelium. But the other big process that's going on here in these patients is really hemolysis and the lysis of red blood cells. And when you start to see large amounts of hemolysis that's really predicted by that LDH of greater than 2000, it suggests that this is a extremely hemolytic process, and biologically there's a lot of overlap with what happens in hemolysis and how that affects the vascular endothelium in this condition. But we're intensivists and pulmonologists, and so we need to think about what are we looking, when we look at a patient with acute chest syndrome, who are the people that are highest risk for acute chest, for respiratory failure? Because those are really the people that are going to end up in the ICU. And so the people who are at highest risk are those who have multilobar disease, like this patient, patients who have underlying pulmonary hypertension. This is a setting where our patients will get transient elevations in their pulmonary pressures during acute chest, and someone who has underlying PH, that's enough to put people into right-sided congestive heart failure. And this is one of the ways that our PH patients with sickle cell disease die. So that's also a big problem in sort of terms of respiratory failure. But thrombocytopenia, and I'm going to show you some data on my next slide to suggest that thrombocytopenia is actually the biggest tip-off that these patients are heading for respiratory failure and death, and really should be a sign. And this is based on a retrospective cohort analysis. So when we think about rapidly progressive ACS, I'm thinking about patients who go from presenting like this patient did, and they are dead within 48 hours. And it is, if you have not seen this in your career, this is a shocking thing to watch. And it is because they're relatively young people, a 22-year-old like this patient. And so this is a retrospective study that included both adult and pediatric patients, and looked back at those who had rapidly progressive ACS. And basically these patients have multi-organ system failure. They have acute kidney injury, hepatic dysfunction, altered mental status, multi-organ system failure, and death. And when they did their multivariate analysis to look at what predicted risk for this rapidly progressive form of severe ACS, thrombocytopenia had an odds ratio of almost 5 as the predictor of acute chest syndrome. What I tell our residents is when the platelets go down, so does the patient. And so it's really the biggest thing to think about. So now our patient's in the ICU. She's intubated. She's now afebrile, but she's tachycardic. Equipment is placed. She's getting an emergent exchange transfusion of 8 units, packed red blood cells. It's now later in the afternoon. Overnight, her mental status is very altered. And so neurology gets called in to see her, and they recommended an MRI of the brain. And so this was her MRI. And so what are we seeing here? And so I left out the check secretary, but I didn't leave out the MRI on this presentation. This is this is basically fat emboli. But what you are seeing here are multifocal punctate lucencies throughout, but both have the entire brain. And so this is fat emboli syndrome. And this is the most severe form of acute chest syndrome. And so fat emboli syndrome is a very vague diagnosis. People think about it in long bone fractures. It also happens in sickle cell disease. Why does it happen? It happens from infarction, bony infarction in the setting of vasal occlusion, usually of the long bones, with mobilization of the fat into the pulmonary vasculature, creating an intense inflammatory reaction within the pulmonary vasculature, and basically leads to, and so it is diagnosed though, and it creates sort of an ARDS type of pathophysiology of just incredible diffuse alveolar damage. Diagnosing it, this is a diagnostic syndrome, another syndrome in sickle cell disease, but basically the major criteria being sort of cerebral involvement. So this altered mental status is a big tip-off that this is going on here, that and thrombocytopenia, but also a petechial rash, with which in many of our Black patients, you cannot see a petechial rash. And so many of our patients, you're sort of going on an ARDS, multi-organ system failure syndrome type of picture, thrombocytopenia, and altered mental status. Other things to be thinking about are a big drop in hemoglobin by greater than 20%, which is associated with hemolysis and jaundice. Having fat globules on either your BAL or in the blood is really very difficult to see and obtain. And in the people that we've bronched before, it hasn't really, we haven't seen it very much. The other big, and people with sickle cell disease related fat emboli syndrome, the other big thing, they all have pain, and they describe it as the worst pain of their life. And so people with sickle cell disease know their pain really, really well. And so when someone says that, it's also a trigger to think about this. The treatment is supportive. And so exchange transfusion is the only thing that's been associated with reduced mortality in this patient population. And so exchange transfusion for everyone. This person's already been exchanged. And so we also do the typical ACS treatment of antibiotics and bronchodilators. And so there are, and so I should have given as one of my disclosures that there is going to be talk about off-label use of medications during this talk. This is going to be one of those instances. So most of what is published on fat emboli syndrome, because it's rare, at our institution, we may see 2 to 3 cases of rapidly progressive ACS fat emboli syndrome each year. And that's a lot. And that's because we have 400 adults in our practice and about 200 kids. And so you may not see it more than once a year or even less. But what we think about is what can we do to reduce that intense inflammation in the pulmonary vasculature. And so plasmapheresis or plasma exchange, which is the goal of which is sort of after the exchange transfusion to do more plasma exchange to get rid of a lot of the inflammatory cytokines, anecdotally seems to have some benefit in this. The use of systemic steroids is controversial. Steroids, so in the mid-90s, there was a publication in the New England Journal that suggested the use of IV steroids increased the frequency of rebound pain in people with vaso-occlusive crises. You say anything increases pain in sickle cell disease, it's banned for like 20 years. So systemic use of steroids is very controversial. I've had a couple of cases over the years of diffuse alveolar hemorrhage in the setting of fat emboli and severe fat emboli that we've used it with some success. And so we put her on post-dose steroids with IV Solu-Medrol, and we did plasmapheresis. After the 8 units of exchange, she on hospital day 4 was extubated. She was intubated during the time of the respiratory failure of the initial day. Her mental status, it was also related to mental status and airway control. Her mental status improved, and by hospital day 12, she was discharged to home on a tapering dose of steroids with outpatient physical therapy and a plan to start chronic exchange transfusions to prevent recurrent vaso-occlusive crises. And so I'm presenting this case because it's sort of the extreme example of acute chest syndrome. And when people think about sickle cell disease and the lungs, this is what they think about. But I think about it much more from the chronic lung disease perspective. And so this is a disease that starts at birth. People are born with sickle cell disease. And so what do we see in our pediatric population? In the pediatric population, it is mostly a disease of the airways. And there is a lot of bronchial hyperreactivity and asthma in our pediatric sickle cell patients. But if you look at, as people age into adulthood, the physiology becomes much more restrictive. But there is data out of Washington University to suggest that the FEV1 decline that occurs as people age from pediatrics to adulthood is a mortality risk factor in our adult population. And so about nearly 20 years ago, we looked back at pulmonary function testing data of 310 adults from the cooperative study of sickle cell disease. This was a multi-center study that was conducted in the United States between 1978 and 1988, and it was supposed to solve all the problems and answer all the questions about sickle cell disease. And it answered some, but many other questions arose. And we looked retrospectively at the data cross-sectionally of 310 adults. And what came out of this was that, first of all, pulmonary function is highly abnormal in our adults. Only 10% of these patients had normal PFTs. And what you saw predominantly was a restrictive pattern characterized by low total lung capacity and reductions in FEV1 and FVC that were really proportional to each other, and sometimes associated with a low DLCO. There were about 13% of patients who had an isolated low DLCO, even when corrected for their hemoglobin level, suggestive of PH. And we don't know, because they weren't doing echoes at that point, because PH wasn't a thing in this disease, how many of those patients truly had pulmonary hypertension. But I will tell you, as somebody who has seen about 50% of our 400 adults over the course in my outpatient clinic, this is a very distant population. And this questionnaire data that was generated as part of my K23, where we asked patients about their exercise tolerance using standard questionnaires, and found that 49% of, and this was data from 146 adults with sickle cell disease, 49% of patients with, approximately 50% of patients with hemoglobin SS disease and 40% of those with hemoglobin SC disease had mild to moderate dyspnea on exertion, or were New York Heart Association class 2 or higher. Meaning, and this was the question that got them this classification, they could not walk 5 blocks on a flat surface or climb 2 flights of stairs. And so this is people in their 20s and 30s. And this dyspnea has plagued me for my entire career, because this is multifactorial dyspnea. And in many of our patients, there also is hypoxia. And so this hypoxia is really interesting. There is frequent oxygen desaturations that occur in our patients, both with exercise, if you do 6-minute walk testing, but also during sleep. Some of it is obstructive sleep apnea related. And this is obstructive sleep apnea without true known OSA risk factors. Like, this is primarily a non-obese population, but they're having OSA with AHIs that are usually in the mild to moderate range in their 20s and 30s. But there's also abnormalities in the oxygen hemoglobin dissociation curve. And so remember, there are things that either will right shift or left shift your oxygen hemoglobin dissociation curve. And so in sickle cell disease, what happens is that there is a right shifting of the oxygen hemoglobin dissociation curve, and it's because of hemolysis. And so in the setting of hemolysis, there's an increase in methemoglobin and carboxyhemoglobin within the blood, and there's also an increase in 2,3-DPG. And both of these things will increase the right shift of your oxygen dissociation curve. So basically, you need a higher level of PO2 to achieve the same oxygen saturation. And so there are multiple mechanisms for which there is increased desaturation in this disease. We've already talked about atelectasis and hypoventilation. This happens in our patients all the time. Rib infarctions from prior vaso-occlusive crises cause there to be splinting chronically, and there's abnormalities in the chest wall related to this. Everything in sickle cell disease used to be attributed to the anemia. And yes, there's an anemia component to the dyspnea and the hypoxia, but it's not all just that. There also may be the presence of both intracardiac and some extracardiac shunting within the pulmonary microvasculature, in case you were wondering where this might happen. That also leads to some hypoxia in this population, or hypoxemia. I'm going to move on to my second case because I know you want to hear something about pulmonary hypertension. And so I don't want to disappoint. So my second case, this is one of the most challenging people in my practice. She's 44. She has when she first presented to me, which was back in about 2019. She has hemoglobin SC disease. Remember the mild genotype, supposedly, retinopathy, and a prior cholecystectomy. So she has a very complicated venous thromboembolism history. Started back in 2012 when she had a left upper extremity DVT that was catheter related. She got 6 months of anticoagulation, then was done with it. March of 2018, she developed bilateral pulmonary emboli. Not on anticoagulation at that time, got heparin, then got placed on apixaban. I saw her for the first time in October 2019. She was short of breath. She was New York Heart Association class 2. She was dyspneic on walking one flight of stairs, climbing one flight of stairs, could walk about 3 to 5 blocks on a flat surface. She had an echo earlier that year, entirely normal. And then things started to go awry. February of 2020, she stopped her anticoagulation because she was having heavy menstrual bleeding. Every time this woman stops her anticoagulation for any reason, she has a new clot. This is the theme here. February 2020, she has a new acute PE in the setting of not being on apixaban. So not apixaban failure. Spring of 2020, we were having a pandemic going on, but here she comes back to my clinic, and it may have been a virtual visit. And she was short of breath on walking less than 1 block and had dizziness, both with sitting, which I wasn't totally sure what to make of that, but also on exertion. And now I'm very concerned she's developed PH in the setting of multiple VTEs, sickle cell disease, and the like. And so what do we know about pulmonary hypertension and sickle cell disease? Well, what we knew back in the early to mid 2000s really was based on echocardiographic studies, initially published by Mark Gladwin when he was at the NIH, where he looked at 175 adults with hemoglobin SS disease and found that 1/3 of them had an elevated TR jet velocity of 2.5 meters per second. And he called those people having pulmonary hypertension. Although, and they had right heart cath data in very few of those patients that was published in their series that was published in the New England Journal back in 2004. Our group and others have identified that this happens in hemoglobin SC disease as well, this elevated TR jet velocity, and it happens at a rate of 10 to 28%. And so a TR jet velocity is the value when you input it into the Bernoulli equation, you end up with an estimated right ventricular systolic pressure. We know that this is not diagnostic of PH, but we also know that a TR jet velocity of 2.5 meters per second comes out to about an RV systolic pressure of about 36 millimeters of mercury. And so while it doesn't mean that these patients have PH, and now we know that this really only has about a 31% positive predictive value, this did predict death for these patients. And it was associated with a 40% 40-month mortality. And the higher TR jet velocity, and particularly those who have a TR jet of above 3, which is about a PA systolic or an RV systolic of above 40, this increased your odds ratio for death of up to 11-fold. And so, but we know, as in every other disease associated with PH, an abnormal echo does not mean you have pulmonary hypertension. You need to go to right heart cath. And we know from the older definition of PH, using a mean pulmonary artery pressure of 25, from now 3 relatively large cohort studies, including the NIH group, but also including a large cohort in France, that really about 6 to 11% of our patients, of our hemoglobin SS adults, have PH diagnosed by right heart cath. With the newer definition, because this is actually usually a mild disease, a milder disease hemodynamically, we're going to get into the hemodynamics in a minute. Using the newer definition of a mean PA pressure of greater than 20, that frequency is actually going to go up. And there's a paper I'm reviewing for the Blue Journal that actually is going to be reflective of this increase. But What we know about echoes compared to right heart cath in this data, this is a meta-analysis that was published by Omar Nis at Cincinnati Children's about 8 or 9 years ago at this point, of 173 patients across 4 studies who had both right heart cath and echocardiographic data. What I can tell you about the hemodynamics in this disease is that many of our patients have combined pre and post capillary pulmonary hypertension. And they may have pre at one point or post at another, but there's a lot of people who are in this group in between. At least 60% of our patients have some component of post-capillary pulmonary hypertension, almost entirely, or I would say 80 to 90% of those, it's related to diastolic dysfunction of the LV. In our case series and in our cohort and others, there are isolated cases of LV systolic dysfunction as well as left-sided valvular disease. That's not actually related to sickle cell disease at all. I have a couple of cases of patients with significant aortic insufficiency, PH related to that in my practice. It's usually aortic valve issues more than mitral, but this is hemodynamically, and Phil and Indy will tell you this as well, this is pretty mild to moderate pH with mean PA pressures of around 34 millimeters of mercury and PVRs that have always been in the less than 2 Wood unit area. And so remember, this is a disease, and we know this from right heart cath data that dates back to the 1950s, where the normal cardiac output is 7 to 9 liters per minute in patients with sickle cell disease, because that is how your heart compensates for chronic anemia. And so because of that, remember the PVR, in your PVR calculation, the cardiac output's the denominator. So having a high cardiac output means that these patients have a baseline PVR of less than 1 Wood unit, or 60 to 80 dynes per second per centimeter to the fifth. And so when we wrote the ATS guidelines that were published now over a decade ago, 2 Wood units was our cutoff actually between normal and abnormal in this population. So it really is, but it's reflective of the cardiac output. Doesn't matter whether or not you have pre-capillary pH or post-capillary in this disease. And these are Kaplan-Meier, this is a Kaplan-Meier survival curve using the older definition of pH. This is a mortality risk factor. We now have had so many studies where pH always comes out as one of the mortality risk factors in our patients with sickle cell disease. In this study from the NIH group, published by Alan Meharry and others, 40% 6-year mortality. And in every form of sickle cell disease of pH, the right ventricle is what dictates what happens to the patient. This is an MRI study using right ventricular ejection fraction, a Kaplan-Meier survival curve, published by the group at Pittsburgh when Mark Gladwin was there. And really, if you had a reduced right ventricular ejection fraction by MRI of less than 32%, that also increased your hazard ratio for death by 3.7-fold. And so this is a bad disease. And so I've spent a lot of my career thinking about and talking about different possible etiologies of PH in this population, or pulmonary vasculopathy. And so there's been a lot of work from Mark Gladwin and others about the role of increased hemolysis and its impact on nitric oxide bioavailability within the pulmonary vasculature as one of the mechanisms for the development of pulmonary vasculopathy. A lot of my research currently focuses on the role of thrombosis, both in situ as well as venous thromboembolic disease. So getting back to my patient, this is a patient who's had hypercoagulability and venous thromboembolism. So what do we know about this problem clinically in sickle cell disease? We're going to get back to my patient, but we got to talk about VTE in this population. This is actually one of the few areas in sickle cell disease where we actually have large data to tell us what is going on epidemiologically. So we know from the cooperative study, Rocky Naik, who's at Hopkins, looked back at the data from the cooperative study and looked at 1,523 patients. By the age of 40, remember, my patient's now 44, 11% of patients will have had a VTE at some point in their life, being DVT, PE, or both. Ted Woon and his group at UC Davis used a Medicare-based claims database in the state of California, larger number of patients, 6,237, more contemporary, and found a similar incidence of VTE by age 40, but this increased to 17% in patients who they defined as having severe disease. How they defined severe disease was 3 or more hospitalizations in the last year. That was it, no other complication. That increased your incidence to 17%. What is frightening about this population is that until 2019, there were no guidelines to recommend extended or lifelong anticoagulation for these patients who are chronically hypercoagulable. I'm going to talk about that hypercoagulability more tomorrow during my talk, but this is a population with a high recurrence rate of VTEs. Ted Wood and his group looked at 877 patients also from the California, this was another Medicare-based database, and found that the 5-year recurrence rate from after an initial VTE was about 24%, and that there is a 3-fold increase in death just from having a VTE. Single center studies at our place and at University of Illinois Chicago and Hopkins look across our lifespan. About a quarter of our patients, 19 to 25% of our adults, have had a prior VTE. I've gotten interested in PH in this space because of autopsy studies in this population. And so if you do autopsies of the lungs of people who die with sickle cell disease of any cause, their lungs are always abnormal. And what you see is pulmonary arteriopathy. And so in figure B and A, you're seeing sort of medial hypertrophy, a plexiform lesion, the pathognomonic lesion of PAH in figure F, and then thrombosis, both acutely in figure C and a chronic one in figure D. So there's coexistence of both pulmonary arteriopathy and thrombosis in this population. The French group tried to look at this with clinical studies. They did a prospective study of 58 patients with right heart cath proven precapillary PH. 41 of them had hemoglobin SS disease, and VQ scans in this population were highly abnormal, particularly in those who had hemoglobin SC disease, to suggest that there's a chronic thromboembolic disease component of their disease. And so I'm going to talk about this more tomorrow at my research presentation. We've created a longitudinal retrospective database of all of our adults with sickle cell disease receiving care since 2003. 19% of our patients have had a VTE. We've had and they were treated for a median of 7 months, because most of this went on before 2019. And they had a 49% recurrence rate. And interestingly, they also had about a 5 to 6-fold increase in ED visits and hospitalizations for each year for the first 5 years post their VTE for vaso-occlusive events and acute chest syndrome. And they also had about a 2-fold increase in mortality. So VTEs are not isolated events. And we've also looked longitudinally at echocardiography. This is work that was done by one of my former fellows, Matt Spring, and he did a deeper echocardiographic phenotyping of our patients with and without a VTE. And we found a lot of abnormalities in both diastolic function as well as of the left ventricle and systolic function of the right ventricle that worsened longitudinally. We had a lot of missing data for the follow-up studies, so we weren't able to really get an impact of I wanted to see worsening of RV function related to those patients who had a VTE 5 years down the road. Our data was muddied by this. And so getting back to my patient, and I'm sorry, I'm moving around too slowly here. Her echocardiogram, and this now we're back in 2020, after her presentation to me, she has normal LV size and function. EF is 62%, normal LV diastolic function and the LV LA pressures, but she has RV pressure and volume overload, and her PA systolic pressure is estimated to be 51 millimeters of mercury. She has a ventilation perfusion scan. It was in the time of COVID, we were only doing perfusion scans, so it was only a Q, no V, and there was concern for chronic pulmonary emboli, but there was no mismatch, and but there was nothing on her CTPA-gram, and so she goes to right heart cath with me, and so her right heart cath shows pH. Her mean PA pressure was 32 with a PA pressure, this is a resting right heart cath, PA pressure of 52/19, RV of 54/10 with a normal wedge pressure of 10. And her cardiac output for someone with sickle cell disease is actually a bit reduced at 4.9. And she had a PVR of 3.78 Wood units. She had a PA-gram at the same time, and she had some slight filling defects in the right upper lobe, middle, right lower lobe, and left lower lobe, but nothing really centrally. And so this is precapillary pulmonary hypertension and sickle cell disease. And so what do we do for this? And so what we do for this, I sort of break it into 4 buckets. If the patient's hypoxic, we put them on oxygen. This used to be a controversial idea in sickle cell disease. We'll move past that because that was really sort of magical thinking. If they're volume overloaded, we use diuretics. There's a concern that if you over-diurese people or if they're dehydrated, they'll have erythrocyte sickling. If they're volume overloaded, they respond fine to diuretics. We also look for and treat underlying comorbidities. We talked about thrombosis, but we also do sleep studies. We look for sleep disordered breathing, but we have to maximize the treatment of their sickle cell disease. And that's what I've learned in this field, that you can never ignore the sickle cell disease. And I think about pH therapy in this realm for the people who have pure precapillary disease. And so the thing is, the sickle cell disease always wins. And I had a patient for many years who I was managing her pH great. And in the end, she died from like a stroke related to her sickle cell disease. And it was a mess. And I thought she was doing great. And then she was not. And so that's one of the things I've learned in this field. So what do we do? So we have now 3 FDA-approved therapeutics in the treatment of pH of sickle cell disease. None of them have been directly studied in this disease. Hydroxyurea is the longest known drug in this space, FDA approved in the mid-1990s. It's not, epidemiologic studies have not shown that's actually protective against pH development, but its benefits are to improve hemoglobin, which helps heart function. And it also reduces the frequency of vaso-occlusive crises in acute chest. And we know that acute chest syndrome for our pH patients is when they develop right-sided heart failure and die. So we recommended during the ATS guidelines, hydroxyurea for everybody. We do not know if L-glutamine, that was FDA approved on its ability to reduce frequency of vaso-occlusive crises, or the monoclonal P-selectin antibody, IV crizolizumab, also approved for the same indication, have any benefit in pH of sickle cell. And so there's been a lot of thought about, if we improve hemoglobin, will that work in this patient population? The French group published provocative data of 13 patients with precapillary pH, now actually quite a few years ago, where they put them on chronic exchange transfusion for a year. And these are exchange transfusions that happen every 4 to 6 weeks. And what they showed was basically an improvement in symptomatology as defined by NYHA class, but also a reduction in pulmonary vascular resistance. And this sort of was the study that led to the NIH-funded multi-center trial led by Mark Gladwin and Daryl Treluzzi, who were at that time were both at University of Pittsburgh, that we're a part of, called the SCD CARE study. We're now just beginning year 6 of the 7-year grant that hopefully will continue funding. And we're about done with enrollment. Enrollment for the study is finishing at the end of this month. So we're going to finally understand whether or not exchange transfusion is beneficial for this population. So what do we know about PAH, pulmonary arterial hypertension medications in this space? We have never, to date, completed a placebo-controlled randomized clinical trial specifically in these patients. And we've actually had 3 failed trials. There were 2 industry-sponsored studies of bosentan for treatment of precapillary pH, and the second one being for postcapillary pH. Both of those were closed before the sample size, the projected sample size was accrued because of difficulties with enrollment. The Walk Fast study was a multi-center trial of sildenafil versus placebo, but not necessarily for pH. It was a study that used TR jet velocity as its entrance criteria. It was stopped early because the patients getting sildenafil had an increased rate of hospitalizations, predominantly for vaso-occlusive events. And so when we wrote the ATS guidelines in 2014, we were really insistent that this had to be cath-proven pH. That's actually, if you ask me what's the main thing that came out of the guidelines, it was to get away from this echo diagnosis and to think about it really only for people who have pure precapillary pH. So similar to where you think about it in a general pH practice. So what do I use for my patients? I do a lot of oral combination therapy. The endothelin receptor antagonists are all well tolerated. Macitentan has become my drug of choice in this population. Riociguat is actually safe in sickle cell disease. We now have published data from the Stereo trial, and this was a safety and efficacy study, primarily a safety study of Riociguat for high-risk patients with sickle cell disease who either had systemic hypertension and abnormal echoes, so it wasn't really a pH study, or a proteinuria study. And this was 100 patients who were randomized to Rio versus placebo. The increased rate of vaso-occlusive crisis did not happen in this population. These were data that were published last year. And so I think about an endothelin receptor antagonist and Rio, and I do in my own practice try to apply risk stratification. So what happened with my patient? She was on apixaban back in 2020, Riociguat and Masi. Anytime she stops her anticoagulation, she gets another VTE. She's also clotted through a number of anticoagulants, and she's now on fondaparinux. I've sent her to our CTEPH program in town, which is at Mass General. They attempted balloon pulmonary angioplasty. She didn't have any improvement in her symptoms, interestingly. In 2023, she presented with worsening dyspnea again. She at one point was up to being able to walk 5 blocks again, back to where she was back in 2019. 2023, things were worse. She was short of breath walking around her house, really minimal exertion. Now she has post-capillary pH on her repeat right heart cath. And so now I have Lasix I have furosemide going as well as the Masi and the Rio. So she's on Masi, Rio, fondaparinux, and Lasix. She now can walk about 20 to 25 minutes. She has been part of the SCD care trial. She's gotten chronic exchange transfusions, not a lot of improvement that she's attributed to this. And it's interesting because she has hemoglobin S(C) disease, so it may not be as beneficial in people who are not as anemic. But this is my last slide. I hope I've impressed upon you that there is a lot for pulmonologists to get involved within this disease. It's a really important cause of morbidity and mortality in our patients. This is a very dyspneic population. Not all of it's due to pH. It's a lot of my patients, it's multifactorial dyspnea. This is really where you need to start, is screening people for dyspnea when they are well. I get echoes on people, ideally every 1 to 3 years. There's not clear how often we need to be getting them. Anybody who has anything abnormal on their echo, they're getting them annually with me. I use 6-minute walk tests in this population as an objective evaluation of both exertional hypoxia as well as exercise distance walked. Think about sleep studies, evaluation for sleep disordered breathing, but there is a ton of work that needs to be done in this field. I'm going to talk more about the venous thromboembolism problem tomorrow in my research talk. I want to thank you for listening, and I will take any questions.
Dr. Klings, that was an excellent talk. I'll open the floor up to questions. I have one statement/question. Do you think every sickle cell patient should see a pulmonologist?
That's a really good question. And I think, in my experience, my experience is a little bit more diffuse in that I will see people just for screening. And so for dyspnea screening, for sort of keeping an eye on their echoes. And I think there is a lot of benefit for that because a lot of our patients are really just being seen by hematology, maybe with primary care, and often primary care doctors don't know what to do with a lot of the patients. So I think there is definitely a role for pulmonologists to see more of our adult patients because this is a very dyspneic population, particularly as they get older. And so we know that their risk of clotting gets higher when they get older, but they also are a population with increased bleeding. And so to be able to sort of balance the risks and benefits of all of that is an important thing. But I also just think, a more comprehensive evaluation is often involved. Some of our patients smoke. There's issue, what is that impact of that on lung function? There's a lot of different ways to sort of think about this. So no, not every patient, But, one of our hematologists asked me, what's the criteria for referring people to you? And I was like, the presence of lungs. But not every pulmonologist is going to be like me. And so, but I think that because you can definitely have a practice of that has a very heavy sickle cell focus.
That was outstanding. Thank you. We've had, this is a little outside of the scope of your talk, but related to the critical care of patients who are coming in with acute chest or sickle cell crisis. We've had a couple of cases recently in our ICU that I'm aware of. There may be more fictitious sickle cell presentation.
With what?
Fictitious sickle cell. And just based on your experience, I'm wondering if this is something that you've encountered in Boston.
And so do they have sickle cell disease?
No, they come in with acute chest. They come in with or mimicking a stroke. And it's horrible because I think this patient population is already stigmatized. There's bias as well.
And so, you've done like a hemoglobin electrophoresis, and it's
well,
normal?
that's the issue. I think it's a real issue. I think, and there's been several case reports of this because there is a time pressure to get a cortisone, to get the exchange transfusion going on. And the hemoglobin electrophoresis can often take some time to come back.
Absolutely.
Right? And so the way we diagnose it. we may have had this. Did you write this up? Did you write this case report? Or did we?
Those are few and far between.
100%.
When people call, the first question I ask is, do they have sickle cells?
Right.
If they don't have sickle cells on peripheral blood,
They do not have sickle cell disease.
That's right.
You will see sickle cells, and that's the easiest way. And we can actually, you don't have to do hemoglobin electrophoresis. You can call lab medicine and they could do a screening test. And that screening test doesn't differentiate between sickle cell trait or the disease, but they will have sickled cells on peripheral blood if they have sickle cell disease.
The other clue in the patient that I had experience with was sort of fortuitously, we sent off a hemoglobin A1C, which they should not be able it was non-existent. And that was the other clue. But I think there've been case reports around patients around the country doing it, either for drug seeking or Munchausen's, and it's taking up some resources. It's not incredibly common, but it's.
So I will have to say, I have not seen that, but one of the other, which Lila was referring to, thank you for being here to listen to my talk and to hear that. But, the other place where people get mislabeled is there's such confusion about what sickle cell trait is versus what sickle cell disease. And so first of all, newborn screening for sickle cell disease did not become universal in the United States until the early 2000s. So many people who are adults with sickle cell disease may not have been tested as a newborn, particularly if they're not from this country. And then even if they were tested, they may not know their trait status. But, it's interesting when our patients go to see physicians, they say they have sickle cell trait. And then it becomes some mishmash of do they have disease or not? And things get attributed to having sickle cell trait that are not attributable to this. For example, I got this patient referred to me a few weeks, he saw me like a couple weeks ago, middle of February, who's a lawyer in Los Angeles, but he was teaching for a month or a week or whatever in Boston. And so he saw a hematologist because he has this episode, he was having these episodes of chest pressure whenever he flied. He traveled all around internationally, and he would develop chest pressure when he flied. And he saw pulmonologists out there, and they kept saying it was related to a sickle cell trait. And I was like, that doesn't make any sense. So we saw a hematologist who was a sickle cell physician at Emory, and was like, this doesn't make any sense. So it turns out, so first of all, half this was actually getting the right history. And so the right history was that he has sleep apnea that was diagnosed over a decade ago, can never tolerate CPAP, so he never wears it. And these chest pressure episodes happens when he falls asleep on the plane. Never happens any other time. And so he's likely getting hypoxic when he sleeps, and that's maybe promoting more sickling from his sickle cell trait, but it's not really sickle cell trait related, it's sleep apnea related. It was like completely convoluted, but the sickle cell always gets blamed for everything. And it may have nothing to do with the entire scene. So I do share, I am a critical care doc, and I do, at our ICU, there's a lot of familiarity because I talk about sickle cell all the time. So our ICU docs are really familiar with sickle cell disease and so, but yeah, no, I would say I have not seen fictitious sickle cell disease in our ICU in my 25 years at BU, but I'm happy to hear that this is, or not happy to hear that this is the thing. Any other questions?
Yes.
Yeah. Oh, hey.
How's it going? Thanks for the talk. So I have two questions. The first is the O2 dissociation curve that you showed. So physiologically, you'd expect with exercise, with the increase in basal metabolite rate and also acidosis, you'll have a right shift in the O2 dissociation curve.
Yep.
Do you find that these folks, so in other words, the tissue oxygen delivery will be enhanced? Do you see that these folks have impaired extraction? And if so, has anyone looked at the mitochondria in these folks?
That's a really good question. So there is some work looking at mitochondrial dysfunction in these patients, going on with Shruti, whose last name I'm blanking on, at University of Pittsburgh, in different situations, because there is concerns that there's abnormalities in how hemoglobin S and oxygen dissociate peripherally in the tissues. And so, and it's really, so I think that the issue of oxygen extraction is real in this disease. And so we haven't done a lot of CPETs in our adults. There is a small case series published in kids to suggest that CPETs, not necessarily invasive ones, but that CPETs are safe. I've done a couple of invasive CPETs in my adults over the years, and they can crank their cardiac output up to 20 liters a minute with exercise, which is really sort of amazing. But it really, many of them don't have the fitness to actually be able to complete a true CPET. But it would be interesting to see if there are abnormalities with sort of extraction from hemoglobin S. Because one of the things, we used to have 4 FDA-approved medications for sickle cell disease. Voxelotor, which changes the configuration of hemoglobin and oxygen, hemoglobin binding to sort of bind more tightly to oxygen, was pulled off the market. And one of the reasons it was that there started to be, in some post-marketing studies, some increased rates of vaso-occlusive crises, as well as increased mortality. But the mortality is a little bit more mixed because it wasn't, some of that was in sub-Saharan Africa, and it seemed to be infection-related mortality. But it also suggests that there's like something with oxygen extraction going on when you reconfigure the hemoglobin S as well. And so it would be interesting to sort of look at in the population, but there's not a lot of data out there sort of across the population.
The second question I have is the PVR in hematocrit has an exponential relationship. And if the wedge goes up, your PVR gets even steeper. Should we be correcting the PVRs for the hematocrit?
That's a really good question. And I would say we don't know the answer to it. There's a paper whose review I need to finish at some point today because it's overdue. But there is a paper that is going to come out from the French group to suggest that there's even a lower PVR cutoff for mortality risk in this population. They did not correct their PVRs for the hemoglobin level, but that is a really good question as well. And it's sort of, and so it would be a really interesting thing to think about in this population if we're really going to focus on PVR and mortality risk.
Okay, I think we're out of time. Thank you, Dr. Klings, and we look forward to your talk tomorrow.